All right, so welcome to part two of our appendicular skeleton lecture, and we're going to be now looking at the bones of the arm. So we'll start off, um, let me see here. We're going to start off by looking at the humerus. All right, so we're going to look at the which generally referred to as the brachium, which just means the upper arm. All right, and so we're going to look at a number of different spots on the arm. So first off, we have our humerus. This is the bone of our upper arm, our brachial region, and we have a head of the humerus. The head of the humerus forms the ball of the ball and socket joint, whereas in the last part we talked about the glenoid cavity or the glenoid fossa that makes up the socket of the ball and socket joint, right? Now, we also have tubercles. These tubercles, we have a greater and we have a lesser tubercle, so you see those here. These tubercles are serving as attachment sites for muscles, primarily the muscles of the rotator cuff. So that supraspinatus, infraspinatus, subscapularis, and teres minor muscles we alluded to last part all attach in some way to one of these two tubercles, so the greater or lesser tubercle. And then as the muscle contracts, it's going to move and it's going to rotate the or in some ways it can abduct, but it will in some way move the humerus to perform some type of motion. We also have a neck of the humerus, right? Now we have two types of necks. We have a surgical neck and we have an anatomical neck. The anatomical neck travels around the junction between the head and the tubercles, whereas the surgical neck runs around in generally kind of the end of the diaphysis of the bone. So maybe in the area where we'd call the metaphysis. So here's the diaphysis, here would be the epiphysis, here would be the metaphysis in the middle. This is a very common site for fracture. So when you fall and you have your arm extended out, or you fall directly on your humerus, sometimes this surgical neck here can fracture. We also have a region called the deltoid tuberosity. Deltoid tuberosity allows for the attachment site of a muscle known as the deltoid muscle that's responsible for a variety of movements, some of them being flexion and extension of the arm, also abduction of the arm, so moving the arm out away from you, right? You also have a region called the capitulum. And the capitulum is this small, rounded, ball-like structure that allows the head of the radius to articulate with the humerus, and so this helps form our elbow joint, or at least part of our elbow joint. Okay, we also have the ulna as well. You then have the trochlea. So the trochlea allows for the articulation with the ulna. And so the ulna and the humerus, the humero-ulnar joint, that is the elbow proper. That is the proper elbow joint, which is a hinge joint, right? We also have medial epicondyles, and condyles are smooth, rounded regions. And so this medial epicondyle is next to or kind of on top of the condyle. And this is one you can feel very easily yourself. So if you stick out your right arm in anatomical position, so forearm facing up toward the sky, palm facing forward and up to the sky, and you go to your elbow region and you feel on the medial aspect of your elbow region, you should feel one very large bump, one very large projection. And if you move just behind that and you push really hard, you should get this nice tingling sensation that runs all the way down your forearm, your hand, and into your fingers. That is your ulnar nerve, right? That is your what we call our funny bone. And so the medial epicondyle serves as a landmark to be able to find that ulnar nerve, that funny bone. But in reality, the medial epicondyle really serves as an attachment site for the muscles of our anterior forearm. So all the muscles of our flexor compartment, so the anterior part of our forearm, all of those muscles, or most of those muscles, run and attach to the medial epicondyle. You also have a lateral epicondyle that allows for the posterior posterior extensor muscles to attach to, right? So if we zoom in and now we look in the forearm, we have a couple of different relevant points on our radius and our ulna. So one point is called the olecranon process. If you flex your arm and you feel the point of your elbow that you're feeling is the olecranon process. This allows for our triceps brachii muscle to attach to. So triceps means three heads, so this is the three-headed muscle, and the three heads of that muscle converge on a single tendon, or really two of the muscles do, or two of the heads do, and then attach to this olecranon process. You also have what's called a trochlear notch, and the trochlear notch articulates with the trochlea that we mentioned in the previous slide, which is a part of the humerus. And so the ulna here with the trochlear notch and then the trochlea itself of the humerus, these two are what come together to make our actual elbow joint, right? We also have a coronoid process. Coronoid process allows for the ulna to slide into a shallow depression called the coronoid fossa, which you find as part of the humerus itself. All right, the olecranon process would slide into a fossa called the olecranon fossa. We have our styloid process. So we have a number of different styloid processes that we'll look at. A styloid process is just a kind of sometimes a very pointed projection of bone that allows for the attachment sites for muscles and other ligaments, right? So we have a styloid process of the radius. We'll see in a second. We also have a styloid process for the ulna, all right? So here's our radial ulnar joint. You have a proximal and a distal. You have a radial tuberosity. Again, a tuberosity is a roughened region of bone that allows for the attachment site for the biceps brachii tendon, its distal attachment. You have an interosseous membrane. The term interosseous means between the bone. So this is a membrane that spans between the bone. And then you have a styloid process of the ulna as well. These styloid processes you can feel relatively easily. And so you have another one here. You can feel these relatively easy on either side of your wrist. You can feel one on the thumb side, which is the radial styloid process, and you can feel one on the pinky side, which is the ulnar styloid process. All right, so let's answer a question here. So which of these statements is incorrect? So read through these, pause the video, and I'm going to move on and go ahead and tell you the answer. So pause the video and I'll move on. So the correct answer is D, right? So the radius and the ulna do not articulate with each other. That is incorrect. That is an incorrect statement. They very much do articulate with each other. They articulate both proximally and distally at the proximal radial ulnar joint, as well as the distal radial ulnar joint. Whenever we do our articulations lecture in chapter 7, we will look at the type of joint that we find between the radius and the ulna. So moving distally to the forearm, so we talked about the brachial region, we talked about the antebrachial region, which is our forearm. Now we'll look at our carpal region, which is named because in that region we have carpal bones. All right, and we have 8 of these. We have a proximal row and we have a distal row. So when you're learning these, sometimes it's helpful to remember which ones are in which row, and then you can also remember which ones start on the left side and which ones go to the right side, or thumb side to pinky side. All right, so we have one called the scaphoid, lunate, triquetrum, and pisiform. Okay, this is the proximal row. So here's our forearm. So this is proximal. Here these are right here. So we have scaphoid, lunate, triquetrum, kind of way back here, and then on top of that you have this pisiform. Right. You then have the trapezium, trapezoid, capitate, and hamate. So if you go back over to the thumb side, trapezium, trapezoid, capitate, and hamate. All right, so you have a proximal row, you have a distal row. These form a kind of condyloid type structure that allows for the articulation with the distal end of the radius as well as the distal end of the ulna. And then distally, this distal row attaches to the row of metacarpals, so the first, second, third, fourth, and fifth metacarpals that make up the middle bones of our hand. Okay, so this is, if you think back to the first part that we did when we talked about the one bone, 2 bones, mini bones, digits, this is the mini bones that we're talking about. The 2 bones was the forearm, so the radius and ulna, and then the 1 bone was the humerus that we did first. All right, so you can look at these and you can see them in this order. So if you go proximal row, lateral to medial, and remember lateral is an anatomical position, so really thumb side, proximal row, lateral to medial, so thumb side to pinky side, you have the scaphoid, lunate, triquetrum, and pisiform. Sometimes you'll see this triquetrum. Sometimes it will be also called the triquetral bone. So if you see the term triquetral and triquetrum, that means the same thing. And then if you have the distal row and you go also from lateral to medial, so again, starting over thumb side, you have the trapezium, trapezoid, capitate, and hamate. So there's a nice mnemonic, and there's lots of mnemonics that you can use to remember these, but here's one right here. So Sandy left the party to take Kathy home. Okay, some are so long top part, here comes the thumb, but that kind of flips backwards, and so long top part, and then instead of starting lateral again, it starts medial, here comes the thumb. So you can use that one. There's lots of different ones, and so I encourage you to make up your own if you want. Find one that resonates with you and sticks with you, and that will help you remember these bones a little bit easier. Okay, all right, so there's a very important clinical correlate to the carpal bones, and this is called carpal tunnel syndrome, right? And we've probably all heard of it. You may have had it, you may have known somebody who had it. Carpal tunnel exists, or the syndrome exists as a result of the overuse and the repetitive use of the hand and the wrist that results in inflammation in a region known as the carpal tunnel. And so if you just know, if you think of the name itself, the carpal tunnel, there is a tunnel that runs through the carpal bones. Okay. So if you look at this section of the hand here, you can see a row of carpal bones here, this inferior row, and then just above it you have what is called the carpal tunnel, and in that tunnel you have different things. Okay, so we have 9 tendons and we have 1 nerve. All right, and so what this so you have 10 things. The main thing that results in the symptoms associated with carpal tunnel syndrome isn't necessarily the tendons, but it's more so the nerve. So the nerve here is called the median nerve, and compression of the median nerve, which is a branch of our brachial plexus that we'll get to in a later lecture. The compression of this median nerve results in numbness and tingling and weakness in our hand, as well as into our digits as well. Okay, you can also get so several of the muscles in the hand are innervated by the by the median nerve, and so you can begin to see atrophy of some of the muscles as a result of their lack of use and lack of innervation by this compressed median nerve. And so the meaty pad of muscle that we think of over our thumb, kind of at the base of our thumb and our palm, that's called the thenar eminence. And there's a branch of the there's a branch kind of coming off this median nerve called the recurrent median nerve that actually innervates that meaty pad of muscle that you can kind of see here. And so this thenar eminence can begin to atrophy and get smaller as a result of carpal tunnel syndrome. So you can see this right here. And so this can be treated in non-invasive ways as well as with surgery. So you can wear a splint. You can try to decrease your use of your hand and your wrist. So if you know you're performing some type of movement or some type of motion, frequently and consistently, maybe try to cut back on that. Inflammatory drugs, ice packs as well to help reduce inflammation. And then if all of those things fail to work, you can have surgery in which they cut this ligament. This ligament here is called the transverse carpal ligament, sometimes referred to as the flexor retinaculum. So that's this one here. There's also this one here that you see in this image. This can be cut, and by cutting it, it relieves the pressure that is being put on these tendons as well as the median nerve, and that helps to reduce the symptoms that are associated with carpal tunnel syndrome and the compression of that median nerve. All right. So if we move past the carpal tunnel, past the carpals, we can get into our last region of the hand, which are the digits. All right. And so we can get into the actual fingers. So we have a row of metacarpals, and then we have a row or several rows of what are called phalanges. Now we have 5 metacarpals on each hand, so we have 10 total. And so we have 1, 2, 3, 4, and 5. The first one corresponds to the thumb. So the thumb is the first digit, and then the index finger is the second, middle finger is the third, ring finger is the fourth, and then our pinky finger, or that one, is associated with the fifth. So you can see 1, 2, 3, 4, and 5. This is that middle row of bones, kind of that runs along the palm of your hand. All right, and then you have different parts. So you have a base way down here, you have a shaft or the diaphysis, and then you have the head, which is making up that proximal row of knuckles. So when you make a fist, that row of knuckles that you see closest to the back side of your hand, to the dorsal aspect of your hand, that's the head of the metacarpal. All right. You then have phalanges distal to that. So we have 14 phalanges. All right. And so we have a proximal and a intermediate and a distal in the second, third, fourth, and fifth digits, but in the first digit you only have a proximal and a distal, so you do not have an intermediate. So this is why we have 3 in the lateral forefinger, or in the medial four fingers 2, 3, 4, and 5, and then only 2 in the lateral most, so in the first finger. So this is why we have 14 total. All right, and so this is a clever mnemonic to help you remember carpals, metacarpals, and phalanges and how many we have. So we work 8 to 5 and we get paid every 14 days. Whether that's true for you or not, I don't really know, but you work 8, so 8 carpals first, 8 to 5 metacarpals, and you get paid every 14 days. You have 14 phalanges total. We'll see something very, very similar, slightly different, but pretty similar when we get down to the foot and we look there and we look at the tarsals, metatarsals, and phalanges, we'll see a very similar distribution. It's not exactly the same. There are different names for the tarsals, but the distribution is very similar. Okay. All right. So answer this question here. You can pause it, and I will move on. So how many metacarpals are there in each hand? There are 5, right? So we have 8 carpals, we have 5 metacarpals in the middle row, and then we have 14 phalanges. So 5 is the correct answer here. We'd have 14 phalanges, and we'd have 8 carpals. All right. So we will stop here, and we'll pick up with our next part by talking about the pelvis and the pelvic girdle, and then we'll move on to talking about the bones of the lower extremity.